The Self Care Learning and Discovery series is back, and it's bigger and bolder than ever. This is the premier self care event of the year, bringing together self care enthusiasts of all backgrounds and disciplines from around the world. The World Health Organization defines self care as the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and to cope with illness and disability with or without the support of a healthcare provider. We also know that self care means different things to different people. What does self care mean to you? You'll have ample opportunity to reflect on this question during the Discovery series, with more than 20 interactive virtual sessions organized by self care experts worldwide. The Discovery series will elevate cutting edge research, programming, and advocacy insights across a wide variety of self care topics, and we encourage you to attend as many sessions as possible, especially on topics that may be new to you. The Self Care Learning and Discovery Series, a core activity of the Self Care Trailblazer Group, is organized by the White Ribbon Alliance in partnership with co sponsor organizations and esteemed steering committee members. We also want to thank all our session organizers and presenters who have voluntarily dedicated their time to curate this event with us. We are pleased to share that every session will offer live, simultaneous interpretation in French, Spanish, and English. To access the interpretation, simply navigate to your meeting controls located at the bottom of your screen. Click on the globe icon labeled Interpretation and select the language you'd like to hear. Joining from your phone, tap on the ellipses to find the interpretation feature and then select your language. Please note, you can switch languages at any time throughout the presentation. The session is now about to begin. Don't forget, whether you're working to influence policies or programs, advance universal health coverage, or improve your own self-care, we hope that you will take the learnings from today's discussion and apply it to your own work. To that end, we invite you to continue the conversation and take action with us by becoming a member of the Self-Care Trailblazer Group. So get curious, jump in, and share your ideas and insights with us. We look forward to advancing self-care together.
Good morning, good afternoon. Apologies for the delay. I'm so pleased to see you all today. I hope that you are having the best beginning of your day or end of your day. I'm really pleased to be here today to talk about self-managed contraception, to talk about knowledge, attitudes, and practices, and beliefs and how they influence self-care programming in humanitarian and fragile settings. I am excited to be here today with a group of wonderful colleagues. To get us started, I wanted to do a brief round of introductions. Joining me here today during this Discovery Exchange session is Caitlin Mannering, the Research Manager for Sexual, Reproductive, Maternal, and Newborn Health at the International Rescue Committee, based in the Washington, D.C. office. We also have Brenda Akut, a program manager from War Adet, a wonderful organization based in Uganda. Justice Muezi, program coordinator for Accord Uganda, also based in Uganda. Juliet Nabunje from the IRC's Uganda office, our Senior Research and Innovation Officer. And rounding out this wonderful group today is Tahirat Omalara and Yola from the IRC's My Degree office in Northeast Nigeria, the Research and Innovation Manager for SRM&H. My name is Natalie Spilotros. I am the Sexual Reproductive Health and Rights Lead for Research and Innovation at the International Rescue Committee, a humanitarian aid organization based in New York, with offices in over 30 different countries across the world. I am excited to walk us through an exciting session today. we will first test some knowledge around self-managed contraception, particularly aimed at looking through some of the questions that our colleagues have used in recent assessments conducted in Uganda and Nigeria. We will review some preliminary results for knowledge, attitude, and practice assessments conducted in 2 different refugee settlement camps in Uganda, and then also in 2 different regions of Northeast Nigeria. We'll then have a question and answer session facilitated by the wonderful Juliet, who led some of that work in Uganda. We'll then take a brief moment to reflect on our own attitudes towards self-managed contraception, which can definitely influence self-care program design and implementation. And finally, we want to hear from you as participants, ways in which we can use this type of data, these types of strategies to inform program design, to course correct program implementation, and to influence the wider practice of self-managed contraception across the humanitarian development nexus. So we're excited to kick this day off today. I'm going to hand it over to my colleague Caitlin to talk to us about why we're leading this session today. Over to you, Caitlin.
Thanks so much, Natalie. 1 in 5 of the world's population currently lives in humanitarian crises with disrupted health systems, including women and girls who are unable to access essential sexual and reproductive health care. This leads to excess mortality and morbidity. As we noted here, the 29 countries with active UN humanitarian appeals in 2023 contribute to a staggering 64% of global maternal deaths and 50% of global newborn deaths. SRH self-care has significant potential in humanitarian settings to fill these gaps in disrupted health systems and enable women to access care during crises. However, investments in and adaptations for self-care in humanitarian settings have been lacking thus far. Next slide. The STTG, IRC, and IWAG codified the importance of self-care to address these critical gaps in fragile health systems, extend health coverage, and improve health equity in a recent global call to action published earlier this year. The global call to action specifically highlights the need to cultivate an enabling environment for SRH self-care research, innovation, and learning in humanitarian and fragile settings. Our hope is that the preliminary findings we present here today will help us advance this policy and practice shift. Next slide. Our specific spotlight today on the importance of assessing self-care knowledge, attitudes, and practice among different self-care promoters is also in line with the SBCC framework for SRH self-care, as you can see on this diagram to your left. Assessing these items can also help program implementers across the nexus design more effective programs that can feasibly be delivered, even in the most challenging and hard-to-reach humanitarian settings. Back over to you. You're muted.
Let's get started. Let's familiarize ourselves with some of the attitude and knowledge items that we included in a recent set of assessments conducted in Uganda and Nigeria. So in order for this to be interactive, in order for us to get picked up and energized at the beginning and end of our days, wherever we are in this world, I'm going to ask you to head over to menti.com and enter the following code. So take a few minutes to find yourself there while I switch my screen over. Okay, again, you can open the menti.com platform on your phone. I find that often to be the easiest way to participate on these online question platforms, or you can open up a new tab on your computer screen. So I'm going to give folks a few minutes to join. And once you join, I encourage you to start answering the first question. Okay, so I'm going to go back and just check to see how many people have joined us thus far. Looks like 0, but when I go to the question, it looks like 6 people have joined. So I'm going to give folks a few more minutes. Again, you can access the online polling platform on menti.com, and you can use the code that showed here, 11084904. So we're going to start today off with a very simple question. Cyanopress prevents pregnancy in women for a period of how long? We've asked this question in English, in French, and Spanish. So if you would like to head to the language of your choice, you can simply scroll to the next screen on your device or platform screen. Okay, so results are slowly coming in. It seems like the majority of participants are choosing 3 months as your answer. So as we have more participants who've just entered our waiting room, we'll give them a few more minutes to catch up, sign on to the menti.com platform, and enter their answers. Okay, so we're at 19 respondents. And yes, indeed, the correct answer is 3 months, although some newer evidence shows that it might actually be a bit longer. But one of the standard answers that we hope health providers and a variety of different self-care promoters can provide to clients interested in Cyanopress and self-injectables more generally is a basic answer around how long does this contraception method prevent pregnancy. Wonderful. Let's head to the next question. So we also saw people answer this question in Spanish and in French, all with wonderful, wonderful responses. Okay, the second question of the day. People are just moving towards all these questions, so that's wonderful. If a woman starts oral contraceptive pills or Cyanopress and soon finds out she is pregnant, this will not affect her existing pregnancy. Again, so just to clarify the question, if a woman starts oral contraceptive pills or Cyanopress and soon finds out she is pregnant, this will not affect her existing pregnancy. And the 2 options available to respond to this question are true or false. So our respondents who answered in English, most of them chose true. Our respondent answering in Spanish also chose true. And then in French, we also saw the same. Okay, and the answer is true. I think that this is a big misconception that we've seen in some of our program work related to Cyanopress and hormonal contraceptive methods more generally. There's sometimes a misconception that it might negatively impact an existing pregnancy. And the reality is that it does not. There's no evidence that suggests that. And so sharing this information and making sure we can address this misconception as part of program startup and implementation can help allay some of the fears that not only self-care promoters, but clients also feel around this issue. All right, let's move forward. Our third question of today that was also included in some of these knowledge, attitude, and practice assessments conducted in Uganda and Nigeria was a simple true or false question that stated the following. All new clients of any hormonal contraceptives should be screened for medical eligibility. Okay, I'm going to ask this one more time. All new clients of any hormonal contraceptives should be screened for medical eligibility. So I see some answers coming in. I also see some new participants who have joined us. If you've just joined us, welcome. We are practicing and testing some of our knowledge around self-managed contraception. So please join us at menti.com. The participant code is included on the top here. Okay, so it looks like our English respondents, the majority of you said that this is true, that all new clients should be screened for medical eligibility. Our French participants or Spanish participants also felt that for the most part this was true. And we also see this trend among our French respondents as well. And yes, this is true. As much as possible, we want to ensure that all clients are screened for medical eligibility criteria. And so the reason why we included this as a knowledge item in a self-managed contraception CAB assessment is because we want to ensure that clients are able to be screened for an initial intake for different self-managed contraception methods at a number of distribution points, not only at the health facility level. So we wanted to better understand how different self-care promoters at the facility level, at the pharmacy level, at the drug shop level, how they understand the importance of a quality cornerstone component of contraception programming, which is medical eligibility screening. So the majority of you understand that importance. We will soon find out whether this was also understood by a variety of self-care promoters working in humanitarian contexts. Okay, let's move forward. Our fourth question of the day. This one is about Ciana breast injection administration. We want to know, after administering a Ciana breast injection, what should one do? What is the next step in the Ciana breast self-administration process? And there are three possible answers. The first answer is recap the needle before disposing of it in a sharps container. 2, leave the needle as is and immediately dispose of it in a sharps container. 3, leave the needle as is and throw it in the nearest pit latrine. Again, 3 possible answers. These were all answers that were listed in our CAB assessment. Let's see what people think. So for English respondents, it seems mixed. About 5 folks thought that the first answer is the correct one. A few more thought that the second one was the right answer. If we head over to our Spanish respondents, we see a similar trend. More people think that the second answer is correct. And then a bit more split on the French respondent side. Okay, so what is the right answer? It's the second answer. There's no need to recap the needle after injection. And we always want to use a sharp container when available and possible. We will soon find out what our other respondents in Uganda and Nigeria felt when they answered this question. Okay, we will continue moving forward. Our fifth question, many of you are racing through these assessment questions, so that's wonderful. For clients with no symptoms or signs of pregnancy, which of the following criteria will allow you to be reasonably certain she is not pregnant? All right, so I'm going to ask this one more time. For clients with no symptoms or signs of pregnancy, which of the following criteria will allow you to be reasonably certain she is not pregnant? Okay. It looks like a variety of respondents chose all of the above. There were many possible choices, but the English respondents felt that most of the reasons here, okay, or symptoms and signs of pregnancy, were all important. Our Spanish respondents also felt the same, and so did our French. Okay, so what is the correct answer? All of the above. So one of the reasons why we decided to include this as a question in the CAB assessment surveys that we conducted was because, again, we want to ensure that self-care promoters at different levels of the health system are also supporting women to rule out pregnancy to ensure that they can safely start a method of their choice. This basic tenet of contraception quality programming is also something that's important to bring into self-care programming that is integrated into a health system. So we, again, wanted to make sure that new promoters of self-managed contraception understood these types of quality programming components. Okay. On to question 6. Okay, what are the health benefits associated with oral contraception? Okay, so there are several potential responses. One includes the reduction of severe menstrual cramps. 2, clearing up acne and improving bone density. 3, the prevention of certain cancers. And 4, all of the above. So some answers are coming in among the English respondents, most of whom chose all of the above. Spanish respondents also tended to choose this last answer, and so did the French. And it turns out that many of you are indeed correct, that all of these are potential benefits for oral contraception. So it will be interesting to see what our colleagues in Uganda and Nigeria chose when they were thinking about all of the potential benefits that hormonal oral contraceptive pills could provide. Okay. And I think also just important that different self-care promoters understand the benefits and not just the side effects, the myths and misconceptions around these different methods that can be made available. Okay, we've got 2 more questions left before we hear from our wonderful presenters. The 7th question, what should a woman do if she forgets to take 1 dose of her contraceptive pill? Okay, there are several options available here, and we found that this is actually a pretty tricky question. It may not be as straightforward as one thinks. So one potential response is that the client can skip that day completely and restart her next dose on the next day. She could take a missed pill as soon as she remembers, and then she can resume taking the pills as usual, even if it ends up being 2 pills that are consumed in 1 day or at the same time. The 3rd potential option is to use a backup method for the next 2 days and then consider taking emergency contraceptive pills if the client had sex in the last 5 days. And then the last potential response that a participant can select is both B and C, right? So the 2nd and 3rd response. So it looks like our English respondents are split right down the middle. One new respondent selected the first option. Our respondents who answered the Spanish poll also seem similarly split. And then there's more of a preference for the last option, selecting B and C among our French respondents. And so what is the correct answer? It is actually B, to take a missed pill as soon as she remembers and resume taking pills as usual. Obviously, using a backup method is totally fine. But again, this 1 missed pill, particularly for combined oral contraceptive pills, this should be a standard response that a health provider should feel empowered to support women when they are dealing with a missed dose or troubleshooting self-administration. The reason why we included this in our CAP assessment is, again, we want to ensure that providers and a variety of different self-care promoters have this basic information to help clients troubleshoot when self-administration can be challenging or confusing. Okay, finally, for our last question. According to the Uganda and Nigeria National Self-Care Guidelines, how many monthly cycles of oral contraceptive pills should a woman be given? Okay, so we have a mixed response here. Again, we want to distinguish what the national Ugandan and Nigerian guidelines say. This is not what the WHO global guidelines say. So we have a variety of responses, and it's pretty mixed across the board. Some folks say 3 months, some people say 6 months, others say 12 months. Okay, and that's among our English respondents. Similarly, we have the same responses among our Spanish and French colleagues, although most say 3 months is the right answer. And correct, of both of those national guidelines, revised the WHO global guidelines recommendations from 12 months to 3 months, taking into account the existing supply chain barriers that the countries both face. Okay, so we're going to pause here because we have exciting presentations lined up. Thank you so much for participating in this short quiz. Please remember some of the answers and the considerations we just discussed as we walk through some of the preliminary results from our work in Uganda and Nigeria. So I am going to switch us over to our presentation. Okay, Justice, over to you.
Yeah, thank you so much, Natalie, our moderator. The participants are all welcome. Let me share with you some brief of background on the CAP survey that we did in Bidibidi and Lamo. Uganda is one of the largest refugee hosting countries in the world, home of over 1.5 million refugees, mostly from South Sudan and the Democratic Republic of Congo and Burundi. The adults and girls in Uganda refugee settlement camps face a high risk of unintended pregnancies and multiple barriers to accessing facility-based care, including language barriers and frequent migration to and from South Sudan. From South Sudan here, because we are working in the northern region of Uganda, so mostly in the northern region of Uganda, we have South Sudan, and they're being hosted in Bidibidi refugee settlement and Alabek in Lamo. Yeah, self-managed contraception has the potential to address these gaps and increase client empowerment. To inform new self-managed contraception programming, it is important that we leverage and improve upon existing self-managed contraception entry points and identify barriers to overcome future programming. Self-care readiness assessment and self-care promoter knowledge, attitude, and practice assessment can be important tools for doing so. Next slide. Yeah, we followed certain methodology to conduct the knowledge, attitude, and practice assessment. And here we had a quantitative assessment of the self-care promoter knowledge, attitude, and practices regarding self-managed contraception using the standardized tool on ComCare platform. The assessment is part of the learning lab phase of 2-year project focused on SRH, self-care for adolescents. Our project is for a period of 2 years, so we are doing the assessment to learn and see how the knowledge and attitude and practice of the self-care promoters in regards to self-managed contraception. Self-care promoters assessed included health providers as well as the drug shop and pharmacy workers. So we did an assessment with those promoters based in the refugee settlement. And these were the pharmacy owners and the drug shop owners and also the health service providers from the existing health facilities within Bidibidi and Parabek in the northern part of Uganda. In the 2 locations, we surveyed 78 self-care promoters, yes, in Bidibidi and Alabek. The data was collected actually in September this year, and results presented reflect mainly the preliminary analysis of the data that we collected. We'll move on. Yeah, as I said, we assessed knowledge, attitude, and practice of the self-care promoters. So there were some questions that we wanted these self-care promoters to share some insights, and one of them was on the correct condom use. And as you see in the graph, relatively we have high levels of knowledge on the use, the proper use of the condom. But as you see in the blue, it is for BDBD, and in the red is parabolic. So you can see that there is a disparity in the two locations in terms of the proper condom use. But when you look at the condom use in terms of preventing both pregnancy and HIV, for BDBD, this time it was low compared to parabolic. So there are those differences that we found out in the two sides. Move on. Yeah, we had other several questions regarding their knowledge, and we looked at if the clients can be, should be screened for medical eligibility in terms of, the contraception, and then if Cyanopress, prevents pregnancy in women for a certain period of time, and we see that we have relatively high levels of knowledge around the need for, medical eligibility screening. People would want them to be screened before you administer or before they take up any contraception. So there was high level of knowledge around that. Then even Cyanopress that can prevent pregnancy for a certain period of time. And when you look at actually the disposal, we had some also questions around the disposal. So you find that the knowledge on Cyanopress disposal steps and oral contraception pill and Cyanopress impacts on an existing pregnancy, was lower, and this was particularly in parabolic. Yeah, can you move on? Yeah, also some questions around the emergency contraception, if they can prevent up to over 95% of pregnancies. And then, what should a woman do if she forgets, take a pill? Also a question about the benefit, the health benefits that we also discussed in the quiz, and the criteria. Which criteria will allow the client, to be reasonable, certain. So you find that you can see that there is low levels of knowledge concerning the emergency contraception, supporting clients to troubleshoot oral contraceptive pill use after a missed dose, describing oral contraception pill benefits, and helping clients rule out pregnancy. So when we ask these questions, subject this question to them, that you can see that there were low levels in all settlements, though there are some discrepancy. On contraception to prevent, they were all at par. Then when it came to, forgetting the pill, BDBD, parabolic, had more knowledge compared to BDBD. Can move on. Yeah, when it came to the attitudes, I think now I can ask my colleague who is online, can join in. Brenda.
Thank you, Justin. Thank you for taking us through the questions on knowledge. Good afternoon, everyone. I'll continue with the section on attitudes. When we come to self-care promoter attitude on self-managed contraceptive methods, in BDBD, we noticed that a number of them were worried about the side effects of the cyanopress, and also there was a high number of them that are also concerned about the inappropriate condom use. In Palabek, as much as the concerns were similar, we also noticed that when it came to the emergency contraceptive pill, there was also a high number of those who are worried about that as well, for its incorrect use. Next slide, please. We also were looking at the perceived benefit on the self-managed contraceptives by self-care promoters, and many self-care promoters in BDBD thought that the cyanopress and contraceptive emergency pills afforded convenience and stigma reduction, and the female condoms specifically offered empowerment benefits to women. In Palabek, self-care promoters identified reduced healthcare workload as a benefit of both cyana and the combined oral contraceptive pill. Convenience was noted among benefits of COCs, condoms, and emergency pills, perhaps due to the large geographical distance between facilities in Palabek. We also looked at, next slide please, Natalie. We also looked at attitude, and I'll request us to pay attention to the ones that we've circled. We asked them about whether contraceptives should only be given to married couples to space children. And although most self-care promoters disagreed that contraceptives should not only be given to married couples, when the question was twisted a bit, and on the second line, it's talking about young unmarried girls, we realized that they changed their attitude in terms of this question. Well, this is not a unique barrier to self-care programming. It is unique in our context because we are particularly targeting adolescents and young people. Also, self-care promoters in both refugee settlements had attitudes around women and girls, self-efficiency in using the self-injectables. So as much as they were looking at it in an open way, when it comes to adolescents, we noticed something different. Next slide, please. Another question was also asked about how self-care promoters thought on women and girls safely storing and disposing sharp objects, especially for the cyanopress. One of the questions we looked at in our Mentimeter, and we saw that 53% of them agreed and 29% strongly agreed. Women and girls being provided with free cycles as recommended by the Ministry of Health in Uganda, 51% agreed and 31% agreed. The majority of the respondents felt that women and girls can safely store and dispose of injectables if well trained and if supported on how to use the injectables and how often the pills should be taken. In practice, we noticed that when it came to some of the job aids that are used for self-managed contraceptives, BDBD had a higher percentage, which was 90%. This could be attributed to the fact that BDBD has been in place before Palabek, and in Palabek it was only at 69. However, when it came to the use of the tools, we found that in BDBD 65% were checking the women and girls for their medical eligibility for contraceptive methods, and Palabek, it was also 65. So the percentages were a bit similar. And these tools support checking medical eligibility criteria, but are less available in both locations. So as much as you find that some of them were not checking, it could be due to the lack of that tool. We also discovered that we have some entry points that we could use for the project. And some of these include that self-care promoters believe that there are very many benefits to self-managed contraception, which include convenience, stigma reduction, women's empowerment. Many of them also believe in women and girls' ability to safely self-inject, store, and dispose of the Sayana first devices. And a few areas of improvement were also noted. For example, the self-care promoters' knowledge on emergency contraception pill use, supporting clients to troubleshoot missed doses of oral contraceptive pills, and ways to rule out pregnancy was relatively low. Respondents were most concerned with side effects of Sayana and incorrect condom use, as well as emergency contraceptive pills. Belief that supporting adolescents to access contraceptives promotes sex was also high among the health workers, and we need improvement there. And then also lack of access and use of the tools for their medical eligibility screening. We came up with some recommendations following the study. And one, we recommend that self-care promoters access tools and information on the medical eligibility screening and the ruling out of pregnancy. We think that area should be improved. We also looked at refresher trainings on self-managed contraception for the self-care promoters. This would be reviewing a wide range of contraceptive methods and their side effects. Then we would also recommend that there is training, content reviews, so that there are ways to support clients to safely and correctly administer the methods and also troubleshoot. We recommend the leveraging on convenience, stigma reduction, and empowerment as benefits of self-care in capacity building opportunities with promoters, because this is something they already believe in. So if we can remind them of this, we believe that this is something that can easily be accepted and it's already positive. We were also looking at exploring ways to pivot from provider-administered self-managed injection among providers already supporting clients to access products, and then also to ensure future self-care strategies and activities, promote inclusion of adolescents, and address provider biases around adolescent contraceptive use. Thank you for listening.
Thank you so much, Justice and Brenda. So we also have a second presentation, so we will hold for questions and answers until the second presentation, but I believe that there are some questions that have been asked in the chat, so continue to ask any questions in the chat and we'll make sure some of the moderators are able to answer. So thank you so much, Justice and Brenda, for giving us a snapshot on some of the knowledge, attitudes, and practices concerning self-managed contraception in Bidi and Palavik refugee settlement camps. Just a quick note to participants, the team also conducted a self-care readiness assessment, which looked at the availability of different commodities, tools, and job aids in addition to this. So that was a complementary assessment, which I believe Juliet presented some results around in a different self-care learning and discovery series. The goal is that eventually when we are done with analysis, we will present the results of both. So without further ado, I wanted to turn it over to my colleague, Tahira Omalara, who will walk us through some of the preliminary data that we collected on CAP, self-managed contraception in Nigeria. Over to you, Omalara.
Thank you, Natalie, for that warm welcome, and many thanks to Brenda and Justus for setting the tone. I'd like to start by providing a brief background about the geographies where IRC works in Nigeria. Our operations are domiciled in crisis-affected Northeast and Northwest. However, our self-care work is currently being implemented in Northeast Nigeria, where as of February this year, there are over 2 million internally displaced persons. People in this region face increased barriers to accessing facility-based care due to insecurity, poor health coverage, inadequate human resource for health, supply chain, and other barriers. Insecure contexts vary across Borno State, where the IRC is currently implementing its self-care programming. For example, in Goza, which is a rural setting, while Maiduguri, which I will refer to as MMC in this presentation, is a peri-urban setting. In terms of displacement conditions, internally displaced persons in Maiduguri have mostly resettled or reintegrated into the urban host communities, while internally displaced persons in Goza are currently living in formal camps with curfews due to insecurity, similar to the refugee camps in BDPD and Palabek that my colleagues from Uganda just described. And in terms of availability of health system access points, such as primary healthcare services, pharmacy, drugstores, this also varies across the both locations, with Maiduguri, which is the urban setting, having more access points. At the IRC, we believe that self-care is a promising solution that can help meet this gap and bring life-saving services closer to crisis-affected populations. Yet, self-care investments are not being made in the fragile context of our country that needs it the most. On the next slide, you'll see what the IRC is doing in Nigeria to address these gaps. We're currently generating evidence to demonstrate feasibility to implement self-care in fragile settings. We're implementing a mixed method research study, which is focused on self-managed contraception, with the objective to understand how displaced married adults, women, and adolescent girls currently practice self-care. We want to identify their preferences and needs for self-managed contraceptive products, and also identify their preferred delivery mechanisms. As part of our objectives, we hope to identify entry points and promising strategies at the facility, provider, and community levels. We're doing this through key informant interviews and the CAP survey that we'll be sharing the findings shortly, and also readiness assessments like Natalie just described. And finally, we want to understand male perspectives and document the role they currently play or can possibly play in supporting access and use of self-managed contraception. Just a caveat, the results we're presenting today are preliminary, as data collection is still ongoing in both Maiduguri, which is MMC, and in Goza. Next slide, please. I will briefly describe the characteristics of the self-care promoters we sampled in this survey. So historically in Nigeria, community health extension workers, whom we refer to as CHOOS, have been the predominant cadre in primary health care settings. However, there has been a recent shift due to increased investment, increased awareness, and increased mobilization for human resource for health, which has resulted to the recruitment of nurses and midwives at the primary health care level. The self-care promoters that we have classified in this survey as others consist of self-care promoters who have varying qualifications. For example, some of them have a BSc in microbiology, in environmental health, and others possess the post-secondary qualifications. And for the pharmacy technicians, they usually operate under the supervision of a pharmacist. They are technicians who supply medicines to patients, whether on prescription or over the counter. In our context, they mostly operate the patent medicine stores like the drugstores. And now we'll be sharing some of the findings from the survey. Next slide. So to some of the knowledge questions, the tools that we used were also standardized tools on ComCare, same with what the tool that was used in Uganda. And what we saw was that there were low levels of knowledge on how to rule out pregnancy across all 4 self-care promoter categories in Goza, which is the rural community where there is limited access to service delivery points due to insecurity and the insurgency. Knowledge was particularly low among self-care promoters that we have classified under the others category. However, interestingly, in MMC, we saw that respondents in that particular category had the highest levels of knowledge on this item, while CHOOS had the lowest. Next slide, please. SI contraceptive knowledge in Goza, we found that more than half of all the respondents did not know how long Cyanapress prevents pregnancy for. From the quiz we just took, we saw that the answer was that 3 months. Cyanapress can prevent pregnancy for up to 3 months, and there are new evidence suggesting that it could even be longer. And then in MMC, this kind of differed by respondent category, with all CHOOS answering correctly and half of all the nurses and midwives, and including the pharmacists, also answering correctly. The lowest levels of knowledge in MMC were among respondents identifying as others. In terms of knowledge on disposal of Cyanapress, this was highest in MMC, where all the nurses and midwives and majority of the CHOOS answered correctly. And then in Goza, we saw that the levels were really low in terms of the knowledge on how to properly dispose Cyanapress, especially amongst nurses and midwives. Next slide, please. So across board, across both locations, we saw that there were low levels of knowledge on the benefits of oral contraceptive pills. And it was also interesting to see that from the Mentimeter quiz, people were a bit conflicted about the benefits. And so this was particularly low in Goza and among respondents in the other category, as well as nurses and midwives. There is a bit of confliction as to the knowledge on the benefits of oral contraceptive pills. In MMC, knowledge was highest among pharmacies, but still low across the 3 respondent categories. So if you remember, MMC is like the urban, peri-urban setting, and there's access to, there are lots of pharmacy drugstores, and so it is expected that they have been providing most of these OCPs to clients, and so knowledge among this category was quite high. All respondents across both locations knew about the importance of screening for medical eligibility for contraceptives. Next slide, please. We also asked them questions around knowledge of condom use, and for the most part, we saw high rates of knowledge around correct condom use, although we also noted some gaps among CHOOS and respondents identifying as other categories, particularly in Goza. But across board, if you look at the graphs, there was high knowledge of the correct use of condom in both locations. Next slide, please. Self-managed contraceptive impacts on existing pregnancies and how to manage the missed doses. We saw across both sides, many respondents did not know that starting an oral contraceptive pill or Cyanapress does not affect an existing pregnancy. This was new to most of them when we asked, and you could also see from the graphs depicting what we learned. particularly CHOOS, and when compared to other cadres, they had higher levels of knowledge on this item. And again, across all the cadres on both sides, approximately half of the respondents knew how to correctly support a client who needed support after missing a dose of oral contraceptive pill. This points to kind of low level of knowledge. Just half of them knew how to, correctly support women to address, to troubleshoot if they've missed a method. Next slide, please. Reports on confidence. Nurses and midwives reported the most confidence in offering a full range of self-care methods when compared to other health cadres. However, we saw that 50% of them still felt that they need information or training. And across the CHOOS and other respondents, we've seen that CHOOS and other respondents were more likely to report a need for more information and then more training on self-managed contraception, particularly the DMPSC, the Cyana-Press, and female condom, because it's not very available in our context, especially in Goza, due to the insecurity challenges. And so self-care promoters are not familiar with this method, and it's expected that they would have challenges supporting women to use this method. And so they've all indicated needing more information, needing more training on this particular methods. Next slide, please. In Maiduguri, reported confidence was much higher across all cadres, with nurses and midwives reporting confidence for all methods except for the oral contraceptive pills and then DMPSC, which is the Cyana-Press, both of which they felt they needed more information and more training on. We saw that nearly half of all the CHOOS and pharmacy technicians reported confidence to offer all methods except for Cyana-Press. Again, Cyana-Press, it's available mostly at the facility level. However, we've seen that there's gap in terms of training for the self-care promoters to be able to effectively support women to self-manage their contraception needs. Respondents in the other cadres were most confident in offering condoms and kind of less confident in offering the other methods. And on the next slide, I'll be sharing some of our reflections from the survey. Yeah. Thank you. We've seen that knowledge and confidence level are generally high in Maiduguri, that's MMC, which is the peri-urban settlement, as compared to Goza. And this is likely due to the poor access, the insecurity, and the low levels of private sector actors and high turnover of health staff in Goza, which is like the rural community that is impacted by conflict and crisis. The security challenge in Goza continues to dilapidate. And we also noticed that confidence is not equal to competence, even though some self-care promoters may have the confidence to offer self-managed contraception, but this does not easily translate to having the competence. And so our data has indicated some relative trends and areas of improvement, including capacity building. We've also noted that CHOOS are demonstrating promising levels of knowledge and confidence, particularly in the more urban sites. This may be as a result of targeted trainings and capacity building. There are lots of INGOs and other organizations that are supporting the provision of health services in the more urban centers. And we've also noted that most of the facility managers are community health extension workers. And so this might be a reason why we're seeing that the CHOOS are demonstrating promising levels of knowledge and confidence, particularly in providing and supporting women to self-manage their contraceptive needs. And we've noted as well that capacity building for self-care promoters may need to integrate more focus on initial screening. It's important that SC promoters are able to screen women for eligibility and also rule out pregnancy, while focusing on new areas like the DMPSC. Particularly from this study, for us, we'll be focusing on respondents that happen to fall in the others category. And finally, we're saying that programs may need to consider creative ways to build self-care promoter capacity, especially when time and resources are limited, particularly in places that are hard to reach, like in our case, places like Goza. Thank you.
Thank you so much, Omalara, for that wonderful overview. So I know that people are likely eager to ask some questions. So I'm going to hand it over to Juliet to moderate a question and answer session and also talk through some more reflections you may have on this data. Over to you, Juliet.
Okay, thank you so much, Nathalie. Thank you so much, the presenters from Uganda and Nigeria. You've really done a great, wonderful job. So to our participants right here, do we have any quick questions we want to bring forward? I know we have been posting them in the chat. That's fine. Please continue posting them up. Yes, so I like the fact that the data presented from both Uganda and Nigeria really reveals the misconceptions, the misunderstandings that most likely may work as potential barriers to proper implementation of our self-managed contraception programs. And also, as we all know that in self-care, we really need the skills of the providers in the private facilities, in the pharmacies, in the clinics, so that they can support in information sharing and empowering the girls and women so that they have the skills to get the method of their choice at their convenience. Therefore, that is a very critical area that we need to dive in. And our researchers from Uganda and Nigeria have done us a great job to highlight the findings from the humanitarian setting. So to start off with our question and answer session, next slide, please. We have some of the reflections we want to reflect on from all of you. Please, you will feel free to come off the mic and answer any of the questions you feel you can, in addition to our presenters. So to start us off, let's discuss the challenges. I know we have implemented this. What we has been presented right now is from the humanitarian settings. But I know we have also done the same assessment or survey in other world and programming outside the humanitarian settings. So we would want to hear from all of you the challenges you might have faced during data collection. Anyone wants to share their experiences in terms of the challenges? So as the participants prepare to share their experiences, maybe we can hear from the presenters about their experiences they faced while conducting this kind of survey. Well, we have our
yes.
Yes, Nicola, please go on.
Thank you, all the presenters. Good morning and good afternoon, good evening to everyone, depending on which location you are. This is Nicholas Otto from IRC, and I'm taking this call from Lamu. Yeah, in line with the first question, the challenges that have been faced collecting that on self-care CAP study. In Lamont and BDBD, one of the challenges that we faced was lack of knowledge and understanding of what self-care is. Yeah, so it wasn't very easy for the respondents or the self-care promoters. Some of them did not have a clear understanding of what self-care is. So we had to kind of explain to them so they can be able to understand and then give us the information that we are collecting. The other one that we faced was also language barrier. I think language was a big challenge because the refugees consist of a diverse ethnic groups with a number of languages being spoken among the different ethnic groups. So that was also a challenge on our side. And so in some instances, we had to get translators to be able to get the information that we were collecting. Then for the case of Yumbe, where the settlements are far apart, there was also the problem of distance, moving from one settlement to the other. For the case of Lamont, is somehow the settlements are not as far as apart from each other as in Yumbe. So that means you have to drive a long distance and take a little bit more time to be able to reach the people to get the data from. And then also the other challenge we found was some of the drug shops or the self-care promoters. Some of those self-care promoters, the drug shops were closed. They were not open at the time of data collection. Yeah, you realize most of the drug shop attendants are actually not probably the actual owners of those drug shops. They could be maybe they were employed or they are relatives of the actual owners of the drug shops. And so they could easily close the facilities and maybe go for food distribution or another activity within the settlement. So we would go the first day, don't find them, go second day, and then the third day, we'll be able to find them. So those are some of the challenges. I think my colleagues can add more because I've left out. Thank you, and back to you, Juliet.
Thank you so much, Nicholas, for that wonderful, very wonderful submission, especially for that first challenge of awareness about self-care. Self-care is the new activity in the country, so most of the providers have not been informed. So it was difficult for them to answer some of the questions. And yeah, thank you so much, Nicholas, for highlighting that. Any other submission from another participant in regards to the challenges they have faced? That is the perspective from the humanitarian setting. Any perspectives anywhere from the world, from another site?
Juliet, it looks like Omalara would love to share some reflections.
Oh, sorry, and thanks for making me aware. I was not seeing that. Please go ahead, Amara.
Yes, thank you, Juliet, for that question. And very similar to Nicolas' experience that he just shared of the challenges in Uganda, we also experienced similar challenges in terms of the lack of knowledge on what self-care means in the context of SRHR, particularly amongst those group of self-care promoters that we have classified as others. And this was also very pronounced in Goza. It was a struggle for us to kind of explain what self-care meant in the context of SRHR. It was new to them. And then we also had challenges with accessibility, particularly in Goza. Most times we have to travel via UN helicopters, and these are not always the most friendly means of accessing these locations. And so we experienced a bit of challenge with accessibility. In terms of availability of the drug stocks, particularly in the rural location that goes at, it's very limited. It impacted our sample size. It was a struggle to find private sectors, private-owned drugstores in those communities as well. Thank you.
Thank you so much, Amara, for sharing those wonderful challenges and experiences. Anything else from anyone? If not, we don't have so much time. I would want us to move this discussion forward with sharing some of the approaches or strategies we have used to better understand providers' competences and some of the lessons learned. Please feel free to come off the mic and share some of the approaches and tools used.
Hi, Juliet. I'm happy to share some different ways we've actually used this data, very much inspired by the RAISE initiative. So big kudos to Sarah Casey, who's actually on the line today. So one of the ways that we've used this data to try to change programming and provider behavior and promoter behavior is actually presenting the data to different groups of people to get them to reflect on what the data means and what the trends mean and what our responsibility is as program implementers, as program managers, as district health officials. So we've done that in different ways and again, not for self-care focused programs, but for like larger sexual and reproductive health programs. We've done that in collaboration with adolescent health committees. So we trained adolescents on how to understand the data, how to use it, how to interpret it, and then had them join us to facilitate a conversation with health providers. So those are just some examples of how we've used this. And I'd be curious to hear from our panelists, ideas that they have to use this self-care data when it is ready, when the analysis is complete. Yeah, I see Brenda's hand up.
Okay, thank you so much, Nefari, for that wonderful submission. Yes, Brenda, please go ahead.
Thank you so much. In our data, we identified some opportunities that we can ride on as a project, and definitely those are some opportunities that we intend to ride on within the project. However, for some of the gaps we saw, where possible, we are developing advocacy issues. Like Natalie said, this data goes out to different stakeholders. It could be the district health team, it could be some of the partners we work with, it could be to the self-care promoters themselves. So we intend to use this data to also ask them for certain things. For example, where their attitudes are different, what can we do about it together? Do we need training? Do we need assistance? Where there are gaps in maybe the medical eligibility testing tools. Do we understand these tools? Do you need training? Do we need to simplify them? Do we need to advocate to the ministry to print out more? Are they applicable to your context, So we want to use this data not only for programming, but also to improve the situation of women and girls in our context. Thank you.
Okay, thank you so much, Brenda. Anyone with another idea on how we can improve the competency of our providers using this CAP survey? Or they can come off the mic and share their lessons learned and how they have applied those lessons in their different programs.
Yeah, Juliet, just to add, in addition to Brenda's submission, for us as well, we hope to use most of the data from the CAP survey to design a values, attitude, and clarification training. So there's what the IRC calls VCAT trainings to help the self-care promoters to kind of change attitude and improve on their knowledge around self-managed contraception.
Great, great. Thank you so much, Omara, for sharing that. Let's move forward with the third question. And I want us to see or look for ways of how we might use and adopt the approaches presented here today. We have listened to very great findings from both settlements, highlighting the capacity gaps and so many other gaps. So how can we adopt the approaches presented to improve our programming? Anyone who would want to answer that? Any panelists? Sorry, I can't see the hands up.
Yeah, thank you so much, Juliet and the people on the call. Yeah, I think what we can do is we can disseminate these approaches to a wider stakeholders and even engage. You know, this is the first of its kind in the refugee setting, where we are trying to understand the self-managed contraception in humanitarian setting, and particularly in the northern Uganda. And in Uganda, there are many settlements across the country, in the south, in the west, and I think a part of the east where we have some IDPs. So I think we can have these dissemination workshops across the board and be able to influence these approaches in other places so that we can have enough evidence to be able to influence the policy at the regional and even national level.
Okay, great. Thank you so much, Adjusters, for your submission. Anyone with another idea?
Hi, Juliet.
Yes.
You know, in really just thinking about the data that was presented, which is all very preliminary. I think we'll have another round of rich data coming our way soon across both countries. You know, I was really just struck by how so many of the components of self-care programming reflect foundational contraception programming, right? Again, they're not separate, they're all integrated. And I think there's a lot that the humanitarian sector can do to really think about how we can promote a stronger self-care lens within existing capacity building materials, right? So it's not additive, it's a revised way of thinking. It's a way of taking the existing knowledge base of all of these different tools and approaches and making them more user-centered and promoting self-care throughout. And so I think there's a lot of opportunities to do so. I think self-managed contraception includes a variety of different products. We often forget that, right? It's not just self-injectables, it's condoms, it's pills, etc. So I think, yeah, it's a great challenge for us as a community. And I'm looking forward to collaboratively working with all of these great self-care advocates to think through how we can do that.
Right. Thank you so much, Natalie. Okay, let's move our discussion to our final discussion point or question that looks at how we might how a program might use this data to accelerate program design or course correction. So how can we use this data to accelerate program design depending on the findings that have been displayed. We have seen that, for example, in BDBD, 56% of the providers believe that contraception is for only those who are married. So where are the adolescent girls and those who are not married? Yeah, so please feel free to come off the mic to share some of your thoughts on how we can use this data to accelerate program design.
Thank you, Juliet. This is Caroline from
Yes.
Uganda.
Okay.
Yeah, the Policy and Advocacy Manager. And thank you so much for all your presentations and all the panelists for their contribution. Yeah, looking at our study as IRC and contribution towards self-contraceptions, I can say I can applaud Natalie for taking initiative to bring this on board, because I can see, looking at our commitment as Uganda, the government of Uganda committed made 5 commitments in the FP 2030. And this is one of the line areas or the focus areas as far as that commitment is concerned, by increasing FP uptake and also reducing the unmet need. And this is what we are trying to do to address all the challenges of unmet need concerning family planning, especially self-contraceptions. So looking at the guideline of Uganda, I can say we are really in line with what we are supposed to do as partners, supporting implementation of self-care. And looking at our statistics and study, I can say this data can support customizing educational materials that can enable understanding existing knowledge based on the study we have done, that can help designing educational program materials to suit the current understanding and level of target audiences that we are looking at. These are the healthcare providers, and then our participants, the beneficiaries of self-care commodities and contraceptions. This data can also be used for behavior change. Looking at the trend going on right now, we all know that there are so many myths and misconceptions regarding contraceptions. Recently, we had controversial argument in the country regarding adolescents taking family planning. And I can ideally let you know that this data is the best fit for us to position ourselves to support program designers to come up with the strategies in changing behavior, in having behavior change to effectively address the challenges the health workers face regarding the policies that are not yet addressed, and also the myths within the community because of lack of right information. This data can as well support as evaluation matrix. And in this case, we are looking at how it can establish a benchmark for evaluating the program, and also enables program designers to set measurable goals and track changes in knowledge and attitudes as far as self-contraception is concerned. When I look at all the challenges we talked about and recommendations, this data can encourage participation of understanding in attitudes to help the providers understanding their roles and promoting programming of self-care. And you know, we have a role as IRC and partners to support the government implementing the guideline. And this is one way that we are also looking at ourselves influencing the implementation of the guideline and other policies, promoting self-care and family planning. So I feel we are at the right time, and I look forward to have this report and have it finalized so that we can support ourselves, develop materials to position ourselves with advocacy issues, and ask for accountability from our policymakers as far as funds allocation and policy change is concerned. This data can also be used for resource mobilization and allocation. We all know that when it comes to prioritization of refugee settlement, emergency response, there's no specific direct fund that looks at addressing SRH issues, especially faced by women and girls in refugee settlement. So this can also be one of our strengths, can be also one of our benchmark, to stand our feet and say, no, we feel like because of this kind of challenges we have, looking at all the challenges we have seen through the study and the myths and misconception, the hindrance they are facing in getting the services, the attitudes of health workers, and fears they have regarding this. We can use this data to see that resources are allocated specifically to address SRH family planning needs in that area concerning our target audiences. Lastly, this data can support us to identify specific areas where knowledge gaps and negative attitudes or poor practices exists. Like we notably presented that the myths and misconception is not only with participants, but even the health workers lack skills on some of this, not only in Uganda, but even in Nigeria, looking at the context that the participants are located in a hard to reach area, and also with the recurring war and war and displacement, both internally and externally. So we look forward to see that this data really adds value into programming and the development of strategies and guidelines. So we feel like we are in the right time, and also we are in the right position, because it's only us that have done this for the first time, as just as said. And I feel like we have all the mandate and power to see that our information changes the trend, the ongoing trend of FP uptake, which we want to see that the unmet need reduces at least to 15%. So it's really something that we can really rely on after the analysis. I look forward to have the team come together and have fact sheets to have this simplified for different audiences to demand for change as far as self-care is concerned and family planning. Thank you so much, Julie. Back to you.
Wow, thank you so much, Caroline, for that very informative submission. And I guess you've nailed it and brought out all the points. Anyone who wants to add anything?
Yeah,
Yes.
thank you so much, Juliet. I just want to add one point, that the government of Uganda is, trying to develop the national guidelines. It already has the draft, but it needs more data, evidence to support the case. So I think this data and the information that we are processing will be very important for the government of Uganda, particularly the Ministry of Health, to know the context of the refugee or the humanitarian setting, because they have done the pilot study, which is more in the stable environment. And this information or the data that we are getting in the refugee setting will be, helpful in redesigning and shaping of the key indicators and any other planned activities that they intend to, implement at a larger scale. So I think it is very key information that we shall have shared with the Ministry of Health in Uganda.
Great. Thank you so much, Justus, for that excellent submission too. Yes, and I think it's the same to Nigeria, where we saw from the findings that the state where there is a lot of insecurity that is very distant, there are very few providers who are willing to go and work there. There is a high rate of staff turnover, and the providers from that state were less confident to provide self-injection to clients and teach them. So this data really will indicate and highlight the key gaps to the policymakers. Any other submission before I hand over to the chair for the session?
I think we are actually out of time. So no more time for submissions, but just a giant thank you to our presenters, our moderators, the participants who joined us today. We look forward to learning and working with you all. Thanks for joining us and have a wonderful day. Enjoy the last few days of the Self-Care Learning and Discovery series. Thanks, everyone. Goodbye.
Thank you. Bye.
Bye.